this week on the BackTable podcast.
This is a procedure that can be very easily implanted into any type of, outpatient facility, to an ASC, to a hospital. The footprint is minimal. The amount of additional instrument is marginal. Basically, this is all, if you're practicing in the US, you will be likely using the Relievant system. It's all disposable trays. So it's very easy to start within your practice. And especially if you're already set up to proceed with vertebral augmentation.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. This is your host, Jacob Fleming, reporting from Dallas, Texas. And today, joining us from the Great White North in Calgary, we have Olivier Clerk. Dr. Clerk, welcome to the show, and thanks for your time.
Thank you so much, Jacob. It's my pleasure to be here and very excited to be talking about some interesting treatments of the anterior column today.
Absolutely. Likewise, I'm very excited. We've been talking more about anterior column treatments, most recently with your colleague, Dr. Ed Yoon, and a recent episode talking about disc therapies. And so the topic today is related, and it's an exciting and emerging topic, which is vertebrogenic pain, and specifically the basivertebral nerve. So really looking forward to talking about this with you and hearing about your experience and kind of the international aspect, the perspective that you have. And so before we jump into the topic for the day, I would like to hear about your background, including where you've lived and trained.
Yeah, absolutely. So I did most of a good portion of my training in Canada. So before even starting in medicine, I did engineering for pre-med. Then I did medical school at the University of Sherbrooke. So Sherbrooke is a city about an hour south of Montreal and a little bit north from Vermont. It is a quaternary center in which I did both all my medicine and residency in diagnostic imaging. After that, I pursue a fellowship in neuroradiology at Massachusetts General Hospital. And this is really where I started to be further exposed to interventional techniques and spine intervention. I worked actually with the great Dr. Joshua Hirsch and started to do lots of anterior column treatments and augmentation procedures. So lots of vertebral augmentation during that fellowship. And then I did a second fellowship dedicated in interventional pain management. So that was at the Spine Fracture Institute in Oklahoma City with Douglas Beall. And this is where I further learned about new interventional techniques. I did lots of neuromodulation, so spinal cord stimulator, intrathecal drug delivery device, and among other essential procedures for our field, interspinal spacers. And after all that, just because I really felt in love with the specialty, I decided to pursue the qualification of Fellow of Interventional Pain Practice, so FIPP. So right now, I'm accredited both in diagnostic radiology and interventional radiology and in interventional pain management. In my current practice, I'm doing both the diagnostic aspect and the interventional aspect on a daily basis.
Very nice. It's definitely a training pathway that it goes a little bit off the beaten path in a few different ways. And I liked that you brought up the FIPP designation, which is something that's kind of interesting. I think that radiologists who are involved in interventional spine and pain management techniques, a lot of us do that without specific fellowship training in that. So people may come from traditionally VIR or musculoskeletal or neuroradiology and kind of start doing these things. But since you had such extensive fellowship experience, you went for this international designation. And I think that that's something that really showcases to the interventional pain community at large that as an interventional radiologist or radiology trained interventionalist in the area, you really are dedicated to the full spectrum of it. Would you agree with that? And what was the experience in studying for that exam and undergoing that certification.
Yeah, absolutely. I completely agree with that. I think as radiologists and as interventionalists, we're very well trained to diagnose images and proceed with therapies. But really, I think the FIPP designation really bring it to the next level and provide, a really comprehensive approach to the treatment, to patient care, and really integrate also physical examination within, especially for the patient's selection aspect. And that's something that I think to have trained in diagnostic radiology, we're less exposed to. And it is crucial. Like our outcome are directly correlated with our patient selection, right? So you can do very well a procedure, but if it's not for the right issue, the right problem, you will not obtain the expected outcome for the patient. So really, for me, having the FIPP certification really did put everything together that basically for the patient that enters basically my clinic currently, I can clinically assess him. We can recommend basically which diagnostic studies needs to be performed, read that study to a very high level, and then suggest interventions. So that really become, the true one-stop shop that you take the patient from as soon as he entered the clinic up to when he comes out of the clinic pain-free or with significant improvement. So I think this is new for our specialty to be able to really follow patients like that. It is the future. It is the way to optimize care, avoid having a patient that will go to various practitioners, various centers to be able to obtain the complete treatment. I highly suggest to interested individual to proceed with that type of accreditation if they are interested in interventional pain subspecialty.
Such an important perspective. I believe that what you're talking about, it alludes to the old adage that we treat patients and not images. And yet, for what we do as interventional radiologists, the imaging is obviously crucial. And so knowing where that fits in and knowing how to interpret all the studies, I think wraps everything together in a very nice way. And with that being said, it seems to me that you have constructed your practice more or less based around that paradigm. And this is, from what I understand, your practice, it's a pretty unique setup. And so I would like to hear about Beam Radiology and basically where did the impetus come from to start what is essentially kind of a small boutique radiology group, and what have been the challenges and the rewards from pursuing that?
Yeah, no, absolutely. It has been quite a ride so far, but we started from humble beginning and now we have 5 locations, 1 outpatient surgical center that, would probably qualify if we were located in the US as an ambulatory surgical center. We have a good portion of the practice that is doing teleradiology. So we're covering 22 imaging center, 1 level 1 trauma hospital, and we have the full suite of radiology that we would expect in any hospital or center. So 3T, MRI, intraoperative CT scan. We have dynamic X-ray, 8 pain procedure room, OR, about 15 ultrasound rooms that, are heavily running into MSK studies. So yeah, it has been quite a journey. We started small, but now we should, I think last time I checked, we were close to 100 employees.
Wow.
And I think the initial interest here was really to build a practice that would allow to proceed with those more advanced interventional techniques. I was very passionate about what I do. And, I think it was missing to have a more comprehensive approach for patients, that patients can rely on one single center or practitioner or practice to be able to have an answer to their interrogation and concern and the treatment within the same facility as well. Because often you can have, a great diagnostic practice that may find the area of pain of the patient, may find a fracture, may find a lesion, and then the patient will have to go to a different center for treatment. So the idea was to build something, a structure that would allow to treat virtually everything. So currently we have, the provincial program for intrathecal pain pumps. We're doing spinal cord stimulator, lots of vertebral augmentation, including, vertebroplasty, kyphoplasty, osseous augmentation, spine jack. We're doing lots of disc augmentation now with some clinical trials that we have, nucleolysis, lots of simple blocks, various type of ablation, from spine, knees, hips, shoulders, lysis of adhesions, even deep facial blocks or ablation that, normally are done more in hospital that we do very safely as an outpatient setting. So we started very small, but now we kind of grown quite a bit over the last few years. And now we're really starting to have, I think a very comprehensive pain practice.
Wow, that's a really comprehensive setup. And I'm sure that many of our listeners are kind of salivating at what you described in terms of the technology you have available and being able to bring that into predominantly outpatient-based practice. That is just really inspiring to hear. And one thing I wanted to ask is how many physician partners are in your group currently?
Yeah, so currently we have approximately 10, I would say 3 to 4 that are more interventional lining. And we have a portion that will be providing more diagnostic reports or will be reading remotely part of the teleradiology aspect of the practice that is mainly in different health jurisdiction, but on site doing more interventional work we're about 4.
Very nice. I think the advantages of that a multifaceted approach are pretty obvious for anyone from the radiology background to understand. The typical difficulties, which you alluded to in terms of we have the imaging technology, but going to the next level and having being able to directly evaluate the patient and perform the procedure for them. It's a gap that can be difficult to fill. Very cool to hear about your success with that. And I'm sure amidst your practice, something that has been crucial to expand this is the treatment of anterior column pain. And so I'd like to dive right in and talk about vertebrogenic pain. So first of all, we'll just start with the elephant in the room. What the heck is the basivertebral nerve? What is it and why ablate it? And just tell us about it.
Yeah. It is definitively a nerve and a anatomical structure that gained lots of momentum and lots of interest in the last few years. I would say even 10 years ago, most of the radiologists or interventionalists did not even know about this structure that now is, in my opinion, essential for any type of pain practice. So the basivertebral nerve is a non-myelinating nerve. So that's one of the key points that differentiate this nerve from, let's say, the medial branch nerve or any other peripheral nerve that you may want to ablate that will regrow with time. This one, once treated with thermal ablation, will not grow back. So this has been very well described with ex vivo studies and also consolidated now with the SMART clinical trial that we have patients that the trial went up to 5 years, but we now have patients coming out at 7 and 8 years that have actually virtually no pain after treatment. So that's a first really key point of this nerve. This nerve is located within the central portion of the vertebral body. So midpoint from, superior end plates to inferior end plates, and about a third ventral to the posterior wall of the vertebral body. So if you take a look on a sagittal T2 sequence, normally you see within the posterior aspects that at the midpoint of the vertebral body, you see a small triangle that starts from the posterior wall. So that is called the basivertebral canal. So this canal will contain a small nerve called the basivertebral nerve, an artery and a vein. And we can treat that nerve by ablation. This nerve will arborize toward the end plate and will bring all the pain afferent from the under the end plates, the superior and the inferior end plates, back to the central portion of the basivertebral canal where the nerve lies. And then the neural afferent will go back to the brain. So in a nutshell, the basivertebral nerve will be responsible for what we call vertebrogenic pain. So pain arising from the vertebral body. There always is a question, well, how can you differentiate this pain from discogenic pain?
Yes.
It can be very challenging. And in my opinion, it's virtually impossible to differentiate both. And the reason is continuing with the pain and the neural afferent back to the brain, the basivertebral nerve will pass through the sinovertebral nerve. And the sinovertebral nerve is also responsible for the innervation of the disc. So because of that neural connection there, it's very difficult to differentiate both. So to determine if the patient has more vertebrogenic pain, we will rely heavily on MRI. Obviously, first, a physical examination. The patient will have low back pain, with flexion maneuvers, sitting, often sitting at 15 degrees, that stress more basically the anterior column. Will the patient have pain when he bent forward with weights, pain with vibration in car and in plane, all those, that are typical for anterior column pain, right? So that's one of the first things that we'll see. And then after that, if the patient has evidence of end plates, modic type 1 or type 2 changes, then, the patient become amenable for a basivertebral ablation procedure, right? So that's a little bit how we can select those patients. That's a little bit what we see. So there's a big component that will be relying on physical examination and also on imaging for that specific treatment.
Thank you for that wonderful overview of the pathophysiology and the workup for these patients. And just as a review for our listeners who are maybe a little bit more removed from diagnostic spine or neuroradiology, the modic changes, like you mentioned, being the absolute hallmark of vertebrogenic pain. And to review, the modic type 1 changes are the edematous changes of the end plate. So that would be bright on T2 weighted, or obviously stir and dark on T1. And then the modic type 2 changes, fibrofatty end plate changes, which are bright on both T1 and T2 sequences. And I appreciate you mentioning the difficulty of differentiating discogenic and vertebrogenic pain. And the sinovertebral nerve specifically, that connection is quite interesting. And I understand it's something that overlap can actually be taken advantage of. And one of the next things I wanted to talk about is you mentioned some of the things that make the BVN different from other nerves in terms of it's not myelinated, it's intraosseous. And because of the intraosseous location, there's not really a great specific diagnostic block in the same way that we would say, for example, medial branch RFA, where the injection, the diagnostic block of the medial branch is very analogous to the ablation procedure itself. Due to just the anatomy, it's not amenable to that. But the overlap with the sinovertebral nerve pathway is something that could be kind of taken advantage of with the anesthetic discogram. And I'm curious, is that something that you use in your approach as sort of a diagnostic block? And if so, can you tell in what context you may use it, or are there times where you're just convinced that it is vertebrogenic pain and to proceed ahead with the ablation procedure?
Yeah, absolutely. I mean, this is a crucial procedure also within my practice. So yes, I do use a lot diagnostic and therapeutic anesthetic discogram quite frequently to confirm that the pain is coming from this specific disc level or from end plates that seems to be degenerated or have modic type 1 or type 2. Also, the modic type 1 changes will be very frequently painful. So the edematous end plate, so bright on T2, hypointense on T1, very, very highly related to pain. I think the last time I checked, about 75% of those patients of those type of imaging changes will be correlated with pain. Versus the type 2, you have early changes and you have later changes. And later changes sometimes may be less painful. So it kind of worth to really determine if the patient would benefit from a procedure, right? So and determine and confirm also that this is really anterior column pain. It's not coming from a different level. It's not coming from facets or any other area that could be a confounding factor in that aspect. So definitively diagnostic and therapeutic and mainly anesthetic discogram is essential. We're doing it on every patient. And if the patient responds well, meaning that the pain will decrease, from a 7, 8, 9 on the VAS scale to a 0, 1, 2, 3, at least, 50 to 70% pain decrease. And then you have also the hallmark of vertebrogenic pain, which is, on the MRI, demodic type 1 and type 2 in a skeletally mature patient. Patient did not responds to conservative care for at least 6 months, then you can proceed with the ablation.
Excellent. Thank you so much for walking through that algorithm. I think it makes a lot of sense, and the parallels to the typical diagnostic block and ablation sort of procedure that's common throughout interventional pain. That parallel is obvious. And again, the differentiating factor being the modic type 1 or type 2 changes. And we will talk a little bit later about how to approach patients who respond well to discogram. But do not have the vertebrogenic changes. So
Yes.
excellent. So we've walked through kind of patient selection, your whole process to that. So now it's procedure day. We have the patient tell us about what's the setting where you're doing the procedure, and just walk us through the operation itself.
Yeah, absolutely. So it's a very standard approach. So similar as, for many of us that do lots of vertebral augmentation. So basically we're passing through a transpedicular typical approach. So we'll be using a 8-gauge, either Beall or diamond tip needle that we introduce via transpedicular approach. The goal is really to bring this introducer needle up to the posterior wall of the vertebral body. Normally, you want to have an angle of attack also that is consistent to ensure that the ablation probe will be able to be exactly in the center of the vertebral body. So in comparison to a typical vertebral augmentation that, you may want to aim for either the superior end plate or inferior end plates, depending where most of the fracture cleft is located. For this one, you really want to be perfectly in the center of the vertebral body. So that's a little bit of a technical consideration that add a little bit to the degree of difficulty of the procedure. So you may want to really proceed a little bit more slowly initially with this transpedicular approach. That is a safe aneural avascular approach, very standard that many of us are performing on a regular basis. But you just really want to make sure that you're well positioned within the pedicle. Just like, for instance, if you're doing a spine jack procedure, right? So basically, if you're putting implants within the vertebral body, same thing. You want to make sure that, you have pretty much a parallel approach to the implant. So whenever you deploy the jack, that's, you can gain as much height as possible with the implants. So same thing. So, but in that case, you want to be parallel to the implant, but also just making sure that the tip of the needle is really in the center portion of the vertebral body. So once the tip of your introducer needle is at the posterior wall of the vertebral body, you will introduce a nitinol J-stylet assembly that is surrounded by PEEK. And this is a curved stylet that will allow you to go closer to the central portion of the vertebral body at the apex of the BVM. Then you push a spatula tip, and this spatula tip will create a channel in which you'll be able to push a bipolar ablation probe. And the goal is really try to reach as much as possible to be at least 1 centimeter ventral to the posterior wall of the vertebral body. And the reason why we want to have that, we want to have enough distance from any type of neural structure. Really, the initial bovine studies with this specific ablation probe demonstrated that most of the neural tissue damage was done in a radius of 5 millimeters surrounding the tip of the bipolar ablation probe. And then after that, for another 5 millimeter, you may have some tissue damage. So you just want to make sure that you have at least a safe radius of 1 total centimeter of safety where there's no other neural structures that you may be ablating. And then once you're well positioned with the bipolar ARF probe, you ablate for 15 minutes at 85 degrees Celsius. So quite simple procedure. You need to repeat that actually at both the vertebral body above and under the segments that you're treating. So for one disc or one segment, you treat basically 2 nerves. So the nerve above and under.
Excellent. The aspect that there's no such thing as a one-level basivertebral nerve ablation procedure, I think is crucial to understand.
Yes.
Also keeping in mind that the access will be unilateral. For each level. So because as long as you can target it in one way, just like doing a unipedicular or otherwise unilateral vertebral augmentation procedure, we don't need ever a bipedicular approach to target the nerve, which helps certainly. So we did talk about how, for example, if the cause of pain were the L4-5 end plates, then you would be approaching both L4 and L5.
Correct.
And do you use sort of an a contralateral approach for that for ergonomic reasons, for example, accessing right side at L4 and left on L5?
Absolutely. Normally, I would start on the left side for the superior level and inferior level on the right side. Yeah. Both. Sometimes you may be able to go on the same side, but it can become a little bit awkward. So, my recommendation definitively is to alternate basically. If you're starting on the right side, second level should be on the left.
Sure. Is your approach to get each of the level cannula in place and then try to burn everything at the same time?
There's some international listeners and listeners also in the US. So in the US, basically, the only system that is FDA approved is the Relievant system. And currently it is one nerve at a time that, we proceed with the ablation.
Sure.
For international listeners, there's some other ablation system that can be used to have similar type of outcome. But currently in the US, yes, it is with the Relievant system, and it's one nerve at a time.
Excellent. So that would probably be an approach of getting access and going ahead and treating. And while that's burning, moving on to the next level, gaining access. I would imagine that's probably the most efficient way to approach that.
Yep.
Excellent. And then one thing I wanted to talk about a little bit is obviously the L5S1 in-plate interface is a common cause of this pathology. And so S1, of course, has some slightly different considerations from the lumbar vertebral bodies. Could you tell us a little bit about that?
Yeah, absolutely. So the S1, the BVN targets for the S1 level is a little bit different. So rather than being, within the posterior third of the vertebral body, you want to be about 50% anterior and 40% inferior to the superior end plate. So slightly different location. I would say that in the majority of cases, it is not too much of an issue to find a target and put the J-stylet in the right area. In some instances, in the high riding pelvis, it can be a little bit more challenging, but normally you're still able to find a window there. There would be technically other ways to do it, but so far, I haven't had any patient that I was not able to access there. Yeah, so slightly different. It does take a little bit longer, and just like for vertebral augmentation, also often the L5 vertebral body, it's a more aggressive approach depending on, the lumbar lordosis. You're using longer access, trocar. So same type of issues that you're also seeing at the L5 level. And S1, well, it's mainly related to the iliac crest that can sometimes obstruct the area, but normally you should be good to find some type of access.
Very nice. I do want to give a shout out to our mutual colleagues and mentors, Dr. Beall and Dr. Nguyen. They had showed me some cases in which they utilized slightly alternate approaches, which made the specific case due to anatomic reasons go much more smoothly or actually be able to proceed, whereas the specific issue may have complicated that. And so for S1, as you said, sometimes with a high riding pelvis, getting that pedicular access can be quite tough. And Dr. Beall has described using several times the trans-ilium approach. And so this is just to tell our readers a little bit, is basically going from a lateral approach through the iliac bone and targeting the BVN that way. And this is something I think that will make a lot of sense for radiologists who think in terms of axial, transaxial, cross-sectional imaging. It makes a lot of sense to see, okay, it's much like a specific lesion biopsy to take the straightest path possible. So that's an alternate method that certainly can be used. Of course, definitely something only to use if you're comfortable with the imaging landmarks under presumably fluoro. Of course, this procedure could be done under CT, but most commonly done with a C-arm. So that's one way. And Dr. Nguyen has shared a case with me of a patient who had prior instrumentation with pedicle screws and had physical exam history and imaging findings that were concordant with vertebrogenic pain. And so, of course, getting transpedicular access when the pedicles are already occupied by screws is problematic. And so using the parapedicular approach that has been described previously is an excellent way to do that as well. And so, of course, spine interventionalists are seeing lots of different kinds of patients with different inborn anatomic factors and iatrogenic factors. So I did want to throw out those. I thought those were some very interesting considerations. And as radiologists, the interventional radiologists, no is not really an option for us. If there is a clinical need to do something and there's a specific anatomic complication, we tend to find a way to work around that. And so hats off to Dr. Beall and Dr. Nguyen for bringing those to the forefront.
Absolutely.
We'll actually have a small presentation. This is some absolutely shameless self-plugging. at the upcoming ASSR, American Society of Spine Radiology conference that by the time listeners are hearing this, it will have already happened. But we do have a presentation talking about some of these alternate approaches to use the BVNA. But as you said, the wide majority of the time, the standard transpedicular access that's tried and true and familiar to many spine interventionalists is going to get the job done.
Absolutely. And I think this is the beauty of having a wide spectrum of intervention within a toolbox, right? We can use tricks and tools that you have learned through other type of intervention. So through time, if you're doing more, it becomes much easier. And I completely agree with you. That's the transiliac approach is a great approach. It's a straight approach. It's an easy approach. We know we use it, for instance, for sacral insufficiency fracture. We use it for, to put screws, to put, different type of implant of material. So, and especially when you can avoid to have too much curvature and just going in a straight pathway, it's always a little bit easier. So this is definitely a great approach. Overall, also for your vertebral body, right? I mean, you're completely right. You can use a parapedicular approach. You can use a modified inferior or superior extrapedicular and plate approach. So depending where you want to end up, there's various ways to access the vertebral body to avoid implants, to avoid pedicle screws. And, the more you know, the more you do, and the more you're able to accomplish and put the needle exactly where you want to. And it becomes easier through time. So these are very wise words and completely agree. Shout outs to Dr. Wen and Dr. Beall.
Yes, definitely agree with that. Always lots of wisdom coming from them. And so I did want to make sure to share that. And we'll also try to share that presentation in the show notes once we have it available. So we've talked about the procedure, some in and outs. Any other pitfalls, any kind of other issues you may have run into doing quite a handful of these at this point?
Yeah. So the only other pitfall sometimes is with the bone density. So sclerosis, right? So sometimes when the bone is very hard, using, a curved intraosseous approach can be a little bit more tricky. This is still a minority of case, and you're most frequently able to drill through it or access where you want to go. But these are the things that, real life experience will bring you at some point. Yeah. But otherwise, it is a fairly straightforward procedure for those of us that are doing lots of augmentation.
Very nice. And I suspect this is going to be an outpatient procedure. And what's kind of the aftercare situation? When do you see the patients back? And are there any sort of post-procedural considerations, peri-procedural care that you go over with the patient, expectations and things like that?
Yeah, so that's an interesting question because I do have lots of interventional colleagues in different countries and continents. And, it's always interesting to see what is being done elsewhere in terms of sedation and post-procedure recovery. We're probably, we're not doing those procedures under GA. We're doing it with fairly light sedation. We're using a gas called nitrox to sedate patients, and we're doing just like a vertebral augmentation. We're doing it mainly with heavy local anesthetic. It's a very short procedure. I do a ton of these procedures. So I would say that the patient will stay about an hour in recovery after the intervention, and then after that they are good to go. So it's a very short procedure for most patients. Obviously, you have those patients with comorbidities or older individual that may stay for a longer period of time. But I would say the vast majority, after 15, 20 minutes, they're ready to leave and they feel great. We do also some, just like after a vertebral augmentation, I do an epidural steroid injection, also just provide some pain relief. So basically the patient will be covered and you kind of bridge the post-procedural pain that they would normally have after an intervention until they do feel the relief. It does take a couple of days before they will feel better, but at least, bridging basically this with an epidural steroid injection is also a good idea. And we know also that, even for, not in all, but in a good portion of patients that have MODIC type 1 or type 2 will have some type of relief with an epidural steroid injection. So really bridging post-procedural pain like this, is part of our practice.
Beautiful. Tell us about the degree of pain relief that you're seeing with patients, and how are you counseling them beforehand for expectations in terms of clinical success, and how are you defining that?
Yeah. So overall, there's two studies that really evaluated BV and ablation, right? So there's the IntraSEP and there's SMART trial. So the IntraSEP followed patient for 2 years, the SMART clinical trial up to 5 years. And so a total of 473 patients are actually treated. And within all those patients, if we just summarize it, I would say 25% of patients have 50% of pain decrease, and the other 75% have about an average of 75% of pain decrease and functional improvements. And within this 75%, you have about another 30% that are almost completely pain-free.
Wow.
So that's very notable. So basically, I would say on average, most likely your pain will decrease for about 75%. And if you're within the lucky 30%, your pain may be completely gone. So yeah, so really good results. Again, we select all patients with what we discussed earlier with an anesthetic discogram. So basically, we're just treating those pain generators that we know will respond well with the BV and ablation. So that does help a lot.
Very nice. And as you alluded to earlier, there's some interesting, unique aspects of the basivertebral nerve itself, and specifically the non-myelated nature. From what we're seeing from the data, it seems to be that for at least the majority of patients, this pain relief is long lasting.
Yes.
It's not something like a medial branch RF where we'll tell the patient months or perhaps longer of relief, but the pain likely will come back. What's the current data on that?
Yeah, so the 250 patients that were enrolled within the SMART clinical trial, at the end of the 5 years, I believe there was still 100 that were still being followed, and all of them demonstrated sustained improvements in pain, quality of life, and function. So it seems to be a permanent treatment. And even there are some of those patients that are now 8 years out and still it seems to be a permanent treatment. So this was already fairly known with some of the ex vivo studies that, ablated basically BVN, waited to see if there was neural sprutening, if there was any type of neural healing, which wasn't the case. So it's one of those treatments, again, that I think is essential within a pain practice and does really change the course of management of patients. Because those patients, we haven't yet dig into that, but it is within a category of back pain that we call stable, either vertebrogenic or discogenic back pain, right? So those patients are not candidates for any type of T-lift, P-lift, any type of spinal fusion. Spine surgeons should not operate on those patients. There's no evidence of instability. Often, unfortunately, in the past, there has been quite a few patients that went to surgery for that because often the patient have no other solution, right? And they want to have something done. And I understand it from a surgical perspective that, you try to help those patients. But now I think we have very strong level 1 data that demonstrate clearly that, hey, there's a better procedure that takes around half an hour to 45 minutes. And that provides, very reliable pain decrease and improvement in function. And the patient will feel the result of that procedure within a couple of hours after the intervention. So doing a fusion or doing even a disc replacement for those patients should no longer be things.
Such a crucial perspective with that you bring up, talking about the treatment alternatives. And this is what's so interesting about this pathology and the treatment is that prior to a few years ago, really lumbar interbody fusion with posterior instrumentation typically would be one of the few things to offer to patients who had failed non-surgical management. And the data on those approaches, as you said, they're, as you might expect, not exactly what I would call encouraging, in that a success for surgical treatment for stable discogenic or vertebrogenic back pain, success is about 30% reduction in pain. And you compare that to potential for 75% or more in 75% of patients. It's sort of a no-brainer. And one thing that I think is so important about this is that the surgeons who, of course, have the fusion capabilities at their disposal, and of course, those are used mostly for instability or deformity. These are not typically the patients who we are seeing with the vertebrogenic pain. These are typically, a lot of them are younger patients, most of them without spinal deformity. And as you said, crucially, that they are stable. And so the surgeons, I think one thing that I really do want to emphasize is they definitely have the capability to use this technique too. And I've seen that as well, that a lot of orthopedic spine surgeons and neurosurgeons have started to employ this in their practice. I think that's great. I'm all for that. I'm all for all spine specialists having as wide an armamentarium at their disposal. But it's certainly something that I feel that the experienced spine interventionalist can bring to a table in a setup, whether that's a hospital or a group or a community where this therapy isn't being used yet. It's a great way to get in. As you said, this is a very unmet need until really a few years ago. So it's still being propagated, and it's a great place for spine interventionalists and definitely interventional radiologists to get involved. And that's one thing I wanted to ask about you. Any advice for spine interventionalists, and particular from a radiology background, to incorporate this into their practice?
Yeah, I mean, this is just like you outlined. This is a procedure that can be very easily implanted into any type of, outpatient facility, to an ASC, to a hospital. The footprint is minimal. The amount of additional instrument is marginal. Basically, this is all, if you're practicing in the US, you will be likely using the Relievant system. It's all disposable trays. So it's very easy to start within your practice. And especially if you're already set up to proceed with vertebral augmentation, this is, in my opinion, a no-brainer, something that you should be adding to your practice. That's, if you're able to do, fairly basic physical examination of the lumbar region that is virtually asking if the patient have pain with flexion maneuvers, pain with sitting, and you see modic type 1 or type 2 change on MRI. If the patient respond also to the anesthetic discogram, failed conservative management for 6 months, you can proceed with this intervention. So then it's easy to learn and fairly easy also to add within your practice. So yeah, I highly recommend adding this procedure to your skill set and your belt. I don't see this procedure going anywhere for the next couple of years.
Beautiful. It's really a rare thing that such a relatively simple procedure is so effective and relatively easy to implement. Like you were saying, it's just sort of a no-brainer. Specifically, if you do have experience doing these transpedicular approaches, which anyone who's done a number of vertebral augmentation is already doing. And so I definitely hope to see increasing radiology usage of this. It's definitely gaining some momentum in the interventional pain community in the US, which again is great. I'm all for the propagation of these techniques and treatments so we can take care of as many of these patients as possible and avoid the downsides of long-term failed conservative / non-surgical management, or unnecessary, more aggressive approaches. And so I couldn't agree with you more on that.
And often, with those new emerging technologies, one of the limiting factors is that unless if you're part of a clinical trial study, you can't proceed with this intervention with part of your practice before there's clear CPT codes. And right now, since actually January of last year, there's, the CPT codes are there, 64628 to proceed with, a 2-level vertebral BVN ablation, 64629. That's, if you're adding another vertebral body. So basically, if you want to treat 3 vertebral body for 2 disc. So the codes are there, added within the AMA, a new code for vertebrogenic low back pain. So M54.51, everything is there. So it's very easy to implement and to get reimbursed also for those interventions.
Amazing. Thank you so much for the billing tidbits there. And of course, they're more than tidbits because the devil is in the details. And if we have an amazing procedure and can't get reimbursed for it, then it's sort of dead on arrival. And this has a lot of momentum, a lot of necessity in the community to employ this approach. And it's practical at this current point in time. And as you mentioned earlier, in different countries, things are going to be a little bit different. But from my understanding, it's certainly gaining momentum, obviously in Canada, the US and in certain countries in Europe as well. So that's great. Hopefully we'll continue to see this propagate worldwide because as we know, vertebrogenic pain knows no boundaries. These are common consequence of the biomechanics of being alive. So it's just an excellent approach. And that's really all I have as far as basivertebral nerve ablation. Do you have any final thoughts on that specific topic before we pivot?
No, I really do think it's an essential procedure for a pain practice. And yeah, I invite everyone to, get trained on it. And if you're not already doing it within your practice, to start doing it. You'll save the life of many patients and change their lives. Just like doing work also on the disc, I think the working on vertebrogenic pain is essential. And that's right now, this procedure has the highest level of evidence, level 1 evidence for vertebrogenic pain. So it is an essential procedure for any pain practice.
And with that excellent segue into allusion to discogenic pain, I do want to talk about some of the even further bleeding edge techniques that you're working on. And you mentioned earlier disc augmentation. So I want to talk to you about your work with that, with the disc hydrogel. And so you've been working on a clinical trial with this. And so just tell us about what's involved with this. Where does this fall in to the anterior column pain treatment option melange? And where are we right now? Where do we expect to see that go?
Yeah, absolutely. So the way that we set up our practice is also to provide high level and high quality clinical trial. And we're running quite a few of these. And a good portion of the interest right now is on the anterior column because, we all know that most of the low back pain is not festogenic mediated, but rather 60% or even more is mediated by the disc, the vertebral body. And currently until, we just talked about PV and ablation, but there's not other minimally invasive treatments that will reliably treat the region of pain. So to palliate to this, there has been for multiple years attempt to inject a gel inside the disc, try to rehydrate basically those discs and provide some support. There was in the year early 2000 a hydrogel called Gelifex that was tested, but they noted lots of expulsion of the material, and unfortunately this did not go too far. So that was a first generation of a hydrogel that was tested. Now there's a second generation that is available that is made with PVA, PVP, and PEG. So basically, it is a gel that you need to heat prior to inject. So you're heating at 65 degrees Celsius. This gel becomes liquid, and you can inject it through a 17 gauge needle. So you're using, classic Cambin triangle approach. You're making sure that the tip of the needle is centrally located within the disc, and then you inject that disc. And so far, we've treated in my center 35 patients. Overall, in the world, I think we're past the 100 patients. In North America, we're actually the only recruiting center right now. And the results are not just good, they're phenomenal. So the average pain decrease of patients with, stable discogenic back pain that had 1 or 2 level of degeneration decreased their pain score from a 6.8 to a 0.9, which is to be permanent.
Wow.
We're continuing to follow those patients, but so far the results at 1 year seems to be quite sustained with no significant adverse events that are device related that we saw within my cohort. So really good results so far. So very exciting technology. It's interesting to see also where the gel lies. Sometimes, the gel lies whenever there's less stress within the disc, which is often where you see either radial or circumferential annular tear. So sometimes the gel will migrate up to the borders of the disc, which initially seems a little bit concerning, but this is purely part of the gel. It will just provide support where there is no support, and follow up of patients of now 2 years plus in other center. The gel just lay there and should be good for actually about 40 years. So
wow,
it seems to be so far a very promising treatment. We're still gaining data on these treatments, but so far very, very promising and an excellent patient satisfaction. I think 95% plus of patients, would suggest these treatments to, family members or other individual that they know. Lots of the individual that we treated, were out of work because of, significant back pain, and they went back actually to work. So
that's incredible. And it really reminds me of what we were talking about with vertebrogenic pain in general, is that prior to a few years ago, this was a problem we didn't really have a good mousetrap for. And a lot of different things have been tried in the disc over the years, from things that are more nucleolytic to things that are actually trying to augment. But as you said, the kind of augmentation approach, it doesn't have anything good available for it, or really anything outside of a clinical trial at this moment. So that just sounds like a really exciting frontier. As anyone who's read spine MRI for more than a day will know, the issues of disc degeneration and annular tears and this whole spectrum is just incredibly common and debilitating. Like you said, some of these patients can't work because of it. And, what are you going to do? Fuse them or put in an intrathecal pain pump? Those are things that happen, and it's not to throw shade on that. And certainly, depending on the individual situation and context, sometimes more aggressive things are necessary. But in general, the entire approach that you're working on it seems to be getting the absolute most ultra minimally invasive way to deal with the given problem. And this sounds like just that for the specific category of discogenic pain. So we definitely look forward to hearing more about that, and certainly hope to have you back at some point in the future to give us an update on that and what we can hope to see in the future.
Oh, absolutely. I have no doubts that we'll hear lots of new developments on the anterior column treatments, on the disc injectables. I think that's one that seems to be very promising, but there'll be probably other also that will may be able to help with larger type annular tear. Also that, normally that we cannot inject gel in those, annular gap or larger torn outer annulus. So that will probably be coming also at some point, but lots of new developments within that field. And I think at the end of the day, everything that we're doing is for the patient and to provide better outcome and less time in the hospital and, faster recovery. And I think really, everything that is happening currently is spearheading in that direction. So it's a very exciting field. And I definitely convinced that within the next couple of years, we'll have very good therapies for the anterior column.
Agreed completely. That's just really exciting. And speaking of new developments and frontiers in spine interventions, are there any other particular developments that you're excited about outside of the disc and the disc augmentation and basivertebral nerve ablation? Any other particular things on the horizon that you're really excited to see where it goes in the next few years?
Yeah, absolutely. So the other thing that we didn't talk, and maybe that's going to be a topic of another podcast, but all those patients that have single or dual level radicular symptoms secondary to a herniated disc, what do you do with those patients, right? So basically there's more and more treatments that are minimally invasive, allow to resorb or mechanically extract basically this herniated disc. One of them that we're working currently is we're performing nucleolysis. So basically you can inject a gas, ozone gas that basically will shrink a small portion of the nucleus pulposus right behind the herniated fragment and will resorb the disc protrusion. And that's, I did 5 or 6 cases right before Christmas and followed on those patients. They're all doing amazing. They have, either significant decrease in their radicular symptoms or completely gone. And I've even followed on a firefighter that was completely out of work, had a herniated disc. I imaged the patient before the procedure and after the procedure, and it looks like there's no neural impingement. The disc is completely, the herniated fragment is completely resorbed. So quite remarkable for a procedure that you can do in such a short amount of time as well.
Fantastic. Yeah, I have to agree. I think that minimally invasive treatments for H&P, as we call it for short, herniation of the nucleus pulposus is another one of these omnipresent problems that plagues adult patients. And there are a lot of exciting things coming out on there. We'll definitely need to have a specific discussion of nucleolysis techniques. And of course, one of my particular interests is the endoscopic spine surgical approaches, which are obviously gaining a lot of traction among the surgical community. I think that's another area that is absolutely the frontier. And as we go further into that area, there's going to be no turning back, which in the best way possible to making treatments for these debilitating conditions as ultra minimally invasive as possible. Really exciting to see what comes out in the next few years.
Absolutely.
Well, Olivier, it's been great talking to you. I want to thank you so much for your time, sharing all your wisdom and experience with basivertebral nerve ablation and talking about other anterior column treatments that are coming out. With that being said, I have nothing else. So the floor is yours if you'd like to promote anything you're working on or have any final thoughts before we close.
No, I think we covered very well the topic there. I think would like to thank you for the invitation. This is quite a fantastic podcast that, interventionalists can go share their experience and enthusiasm and new techniques and ideas with the community. So thank you for hosting this podcast and continue doing the great work that you're doing. And happy to come back, if there's any other topic of interest. Otherwise, until next time.
No question. We would definitely like to have you back. I think we've outlined multiple potential topics for the future. And so with that in mind, for our listeners, thanks for tuning in and catch you next time.
Thank you. Bye-bye.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jamila Kennebrew.
Thanks again, and see you next time.